Hi, Shaswini. You there?
Hi, mom. Yeah, I'm there, mom.
Yeah. Okay, my screen is visible.
Oh, yes, mom. It's visible.
Okay. So we'll start.
Oh.
Okay. So today we are going to deal with molar pregnancy. So it is a very important differential diagnosis if a mother comes with bleeding in first trimester. So if she comes in with bleeding in first trimester, there are important differential diagnoses you have to think of. So like threatened abortion or incomplete abortion, or it could be just implantation bleeding called as a placental sign, or ectopic pregnancy or molar pregnancy. So these are the very important differential diagnosis if the mother comes with bleeding in her first trimester. So today in detail we'll be dealing about molar pregnancy, and it is a component of something called as gestational trophoblastic disorders. So GTD. So in gestational trophoblastic disorders, it is divided into benign and malignant. So molar pregnancy is a benign component. So it could either be complete mole or a partial mole. So today we'll be dealing only about the benign component because this is an object X topic. So when we go to gynecology topics, we will discuss in detail about GTN, that is gestational trophoblastic neoplasia. Okay. So the next, so today's class, what all we'll be discussing. So we'll have a brief introduction of what is molar pregnancy, the classification of molar pregnancy or the classification of gestational trophoblastic disorders. What is the incidence? What is the pathogenesis? And what is the main hypothesis behind the formation of moles? And what are the main risk factors which contribute to it? And if a mother or if a pregnant mother has molar pregnancy, what are the most common clinical features she presents to you with? And how do you differentiate between a complete hydatiform mole and a partial hydatiform mole? How do we investigate her and management? And the very important thing is the post molar evacuation follow up. So this follow up will be asked to you both in your practical exams and in your theory exams. So this is very important, and it's also important in your day to day clinical practice as well, not only in exam point of view. So if you encounter a molar pregnancy and if you have done a suction evacuation, which is the gold standard to be done in the management. So post evacuation, how do we follow up and what does the present guidelines tell? So textbooks give a different thing, but present guidelines have a particular way or particular protocol for follow up. So we have to be following it. Okay. So let's move on to what is gestational trophoblastic disorders. So it is there in the 1 second. So we have to be knowing what is gestational trophoblastic disorders. So it is gestational means it is a pregnancy as well. It is not something like ovarian carcinoma or cervical carcinoma. It is nowhere related to pregnancy or its sequelae. But gestational trophoblastic disorders is one of the component of pregnancy, and it might lead to a sequelae post normal pregnancy also. So GTDs is not a characteristic of only pregnancy, but it could occur. GTN, that is gestational trophoblastic neoplasms, can occur even after a normal pregnancy. This is what is one of the very important things. See, for example, now if she has a molar pregnancy, you might think she might have a persistent gestational trophoblastic disease and it might progress to gestational trophoblastic neoplasm. That is all well known. But even a normal pregnancy or a normal abortion or an ectopic pregnancy could also lead to a gestational trophoblastic neoplasm. So it is everything to do about pregnancy. So that is the term which is described as gestational trophoblastic. What is trophoblastic? This is a very important proliferation of the placenta. So it is the proliferation of the syncytio and cytotrophoblast. So mainly the syncytio trophoblast, and that is why it is called as a trophoblastic. And obviously it is a neoplasm, and hence in gestational trophoblastic neoplasm, it is a malignant or it is a malignant form. But there are certain benign forms of it also, which we commonly called as molar pregnancy. So in the benign form, we have complete hydatiform mole and the partial hydatiform mole. So that is the two important things that we are discussing today. And these might lead to the gestational trophoblastic neoplasms as well. So there are certain neoplasms called, and there are different types. So what are the types? Invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. So these are the four types of GTNs. But in GTDs, which are the benign form, we have complete mole and the partial mole. So GTD is a term which is described as a heterogeneous group of interrelated lesions that arise from the abnormal proliferation of the placental trophoblast. So it is mainly the proliferation of the placental trophoblast. So usually they'll be inside the uterus. So if they invade the uterus or if they metastasize to different locations, we call it as a metastatic disease or a benign disease. So usually this complete and partial moles are confined to the uterus. The metastatic sequelae is very less, as less than 1 to 2%. But sometimes if they progress to GTN, there might lead to a persistent GTN or persistent GTD, which might progress to GTN. So clear till now?
Oh, yes, ma'am.
So it is mainly benign, that is the pregnancy related things. Why is this not working? My screen is visible.
Yes, your camera is showing, ma'am. Screen is not visible now.
Okay. Next, we have to discuss about the hydatiform mole. So in hydatiform mole, that is the benign form of GTDs, we can divide it into a complete hydatiform mole and a partial hydatiform mole. But before we divide, so we have to know what are the main risk factors and what is the incidence of hydatiform mole. Okay, just a minute. So the main incidence of hydatiform mole, it has the highest incidence in Oriental countries like Philippines, China, Japan, and the highest incidence is seen in Philippines, that is 1 in 80 pregnancies, and it is lowest seen in European countries, that is around 1 in 752, and in USA it is very less, that is 1 in 2000. But in India, we have an incidence of about 1 in 400. Okay. So this is the main incidence of the hydatiform mole. Coming to the risk factors. So here we can see the risk factors of hydatiform mole. So the main risk factors are the maternal age. So extremes of age group are at a higher risk of hydatiform mole or a molar pregnancy. So why extreme age groups are at a risk factor? Because of the oocytes. So these oocytes in the extremes, especially after 40 years, these are old aged oocytes or mature oocytes, which are old aged, means they have aged for a longer time. So these oocytes are a higher risk of development of this. The nuclear material inside the oocyte will cause apoptosis. So whenever the nuclear material of the oocyte causes apoptosis, there might be fertilization with one or two sperms, which might lead to the complete mole or the partial mole. So this oocytes which are aged will have the apoptosis of the nuclear material, which might be the main reason for development of hydatidiform mole. So that's why less than 20 years, the development of hydatidiform disease is around sevenfold higher. So even if it is less, like usually they tell, if the age group is around 15 to 20, sevenfold higher of development of GTD. But if the age is more than 40 years, there is 20 2 to 10 fold, that is more development of GTD. And even the prior risk of abortions also is important. So if there is one abortion, then the relative risk increases to 1.9 to 3.3. But if there are two or more abortions, there is 32-fold of development of molar pregnancies. Even in the nulliparous woman, the chances of molar pregnancy will be high. So all these are different theories, but there is no reasoning why there is more development. Only for the maternal age, it is being described in the GTG. Okay. And as I told you, the Asian women are more prone when compared to the European women. So Asian women 1 in 387, or in India it is 1 in 400, and non-Asian women it is around 1 in 752. Whereas in Philippines it is the highest incidence, that is 1 in 80. Okay. And if there is any prior molar pregnancy, there might be 1% chance. If there is no molar pregnancy, there is 1% chance. But if it is more than one molar pregnancy, there is 16 to 28% chance. So if there is one prior molar pregnancy, there is 1% chance of recurrence. But if there is more than one time, if she's got molar pregnancy, there is very high incidence of 16 to 28%. And if there are any presence of theca lutensis, the gestational trophoblastic diseases develop in about 50% of the population. And also, if there is any history of infertility and smoking, there might be also a risk factors for GTD or development of molar pregnancy. So these are all well proven, but there is no particular reasoning. So maternal age, prior abortions, prior molar pregnancies, nulliparous women, the ethnicity and race, and the presence of theca lutensis, infertility, and smoking. So these are the different risk factors for molar pregnancy. So incidence in India is about 1 in 400. Okay. So next, coming to complete mole and partial mole. So in complete mole, we have to understand what is the main pathogenesis behind development of complete mole. So how does it develop? So we have to mainly understand that there will be an empty ovum. So if there is an empty ovum, if it is fertilized with a sperm, with a single sperm, and there is endoduplication of this sperm, and it leads to 46XX. So there is empty ovum. So there is no maternal genome. There is a completely paternal contribution. So from this sperm genetic material will cause an endoduplication, and it will result in a homozygous molar pregnancy. So this will be one of the important pathology behind development of complete mole. So when there is no maternal component, it is only the paternal component. So then, or if there is a single ovum, so this endoduplication happens in 75 to 80% of the population. And sometimes an empty ovum plus two sperms, that is called as dispermy. Dispermy. So when there is a single ovum but two sperms are fertilizing this ovum, it is causing 46XX. So this also will lead to a complete hydatidiform mole. And if there is an empty ovum, so this is around 15 to 20%. And if there is an empty ovum, so XX or XY, whichever the sperm is fusing, so this is less than 5%. And usually YY will not be a viable pregnancy. So usually X is required for the survival. But if there is 46YY, that is a non-viable gamete. So that will not fertilize. So you have to always remember that complete molar pregnancy is diploid. So it is a diploid pregnancy, but there is no contribution from the mother It is the only contribution from the father's side. So it could either be the endoduplication of the genetic material of the paternal component, or it could be two sperms fertilizing a single ovum. So that is called as a dispermy. So this is the main reason behind development of complete hydatidiform mole. So this is the gross appearance of the complete hydatidiform mole. So we can see the grape-like vesicles, and this is the proliferation of the trophoblastic tissue. So we can see the expulsion of grape-like tissues or grape-like vesicles from the vagina. So this is the very important pathognomonic feature of a complete molar pregnancy. And this is the histopathological examination finding. So there is complete proliferation of the trophoblastic tissue, and it is not focal, it is a diffuse proliferation of the trophoblastic tissue. And you have to remember that there is only placental tissue or only trophoblastic tissue. There is no presence of any fetus, or there are no fetal parts. So this is completely the proliferation of the trophoblastic tissue. We cannot notice any fetal parts in a complete hydatidiform mole. Okay. So next, coming to what is the pathogenesis behind a partial molar pregnancy. So in partial molar pregnancy, we have to remember the ploidy status is triploidy. That is, there are three sets of chromosomes. In a complete molar pregnancy, there were two sets of chromosomes. But in a partial molar pregnancy, there are three sets of chromosomes. So we can see a single ovum. Either it is fertilized by two sperms. So it is called as diandry. So that is, there are two components of the paternal genetic material. So it is either XX or YY. YY will not be X. So it will cause YYY will not be a viable gamete, but XX or XYY or XXY, all the three will result in a partial molar pregnancy. Okay, so this partial molar pregnancy will have both the trophoblastic component plus the fetal parts. So this is how we differentiate from a complete molar pregnancy. So we can see a fetus along with the proliferation of the trophoblastic tissue. And here, instead of diffuse diffuse proliferation, we can see only some focal proliferation of the trophoblastic tissue. So this is called as the scalloping of the chorionic villi. There is no diffuse proliferation. There is some amount of focal proliferation of the trophoblastic tissue. So there are many spaces. There are cystic spaces in the placenta, and it's also called as a Swiss cheese placenta. Swiss cheese placenta. So what is Swiss cheese? It has too many lacunae. So the placenta has too many cystic spaces. So too many cystic spaces and focal trophoblastic proliferation, along with the features of some chromosomal anomalies in the baby. That is mostly there will be triploidy features. So these all contribute to the partial molar pregnancy. Okay. Now I have to discuss how does this formation of grape-like vesicles occur. So we have to always know how does this formation of vesicles occur. So I told you there is the empty ovum with the sperm, and there is endoduplication, and there is some genetic material either diploid or triploid based on the which molar pregnancy. But how is this grape-like vesicles formed? So we have to understand there are two theories behind the development of or the hypothesis of a molar pregnancy. So what is the hypothesis of molar pregnancy? So one is the Park hypothesis. The other one is Hurtig hypothesis. So what is Park hypothesis? So Park hypothesis Firstly, there is primary disturbance in the trophoblast. So because of this genetic alteration, there is disturbance in the trophoblast. So this results in structurally and functionally abnormal trophoblasts. Abnormal trophoblastic tissue. So this causes excessive absorption of fluids into the villi, into the trophoblastic villi. So this fluid absorption causes distortion of the blood vessels in the placental tissue, distortion of blood vessels. So this will cause the death of the embryo of whatever it is formed. So there is no embryo, there is only the proliferation of the trophoblastic tissue which is occurring. So this is Park theory where there is primary disturbance in the trophoblastic tissue which results in abnormal both functionally and structurally of the trophoblastic tissue. Because the trophoblastic tissue is abnormal, there is absorption of fluid from everywhere and there is development of these vesicles or the grape-like vesicles, and this grape-like vesicles cause distortion of the blood vessels which are present in the placental villi. And because there is distortion of the blood vessels, there is death of the embryo. And there is death of the embryo, there is no fetal part, there is only the cystic spaces or there is this vesicular formation from the abnormal trophoblastic tissue. So this hypothesis was brought by Park. But then this was modified and it was told that it is not the primary disturbance of the trophoblast, but initially because of all this genetic alteration, initial thing which happens is the death of the embryo happens first, which causes of distortion or disappearance of the blood vessels. Because there is no blood vessels or no blood supply, there is accumulation of fluid in the trophoblastic tissue, which causes the swelling of the villi, placental villi, which causes the absence of fetal parts and formation of grape-like vesicles. So this is the most newer theory and the most accepted theory is the Hertig's theory. So if you ask which is most evolved and which is more proven to be right, it is the Hertig's theory which is proven to be right. So this is the main hypothesis behind development of a hydatidiform molar pregnancy. So I will repeat. So I will repeat only Hertig because this is more important. So because of the genetic alteration, there is death of this embryo. Because the death of the embryo, there is disappearance of the blood vessels. And as there is distortion and disappearance of the blood vessels, the placental tissue will start accumulating the fluid from outside. And this accumulation of fluid will cause the swelling of trophoblastic villi, which further proliferates and which leads to the pattern of grape-like vesicles. So this is the main hypothesis behind development of the vesicular or grape-like vesicles. So, understood? So, Mary Madam, can you brief out about the karyotype in the complete hydatidiform mole and partial hydatidiform mole? I'm not able to hear you, Madam.
Please repeat, ma'am. Hello?
Oh, yeah, I can hear you now.
I couldn't hear you. Ma'am, question now?
Yeah. Can you tell me how does this complete hydatidiform mole and partial hydatidiform mole, what is the genetic alteration which takes place?
Ma'am, empty ovum with 23 eggs, ma'am.
Mm,
It is
I will repeat then now.
right, ma'am.
So, there is no genetic material from the ovum, or there is no genetic material from the mother's side. So, there is an empty ovum, plus there is a sperm which fertilizes this empty ovum. So the sperm gives some genetic material, that is 23 eggs. And this 23 eggs from the sperm will cause endoduplication, which causes 46 XX. Okay, so this is one form of development of complete mole. So this endoduplication occurs usually in 75 to 80% of the complete form of pregnancies. But sometimes an empty ovum will be fertilized by two sperms. So there is one sperm, 23X, second sperm, either 23X or 23Y. So this causes a heterogeneous picture. 15 to 20% will be 46XX and around 5% will be 46XY. So this also, the complete genetic material is come from the paternal side. So there is no maternal contribution. So this results in a complete herediform mole. So this is a diploid pregnancy, but the entire genetic material is a paternal component. That is why there is no fetal parts, but there is only visualization of grape-like vesicles. So this is only trophoblastic proliferation is seen, but fetal parts are not seen because there is no maternal contribution. Next, so there is only grape-like vesicles and there is diffuse proliferation of the trophoblastic tissue. Unlikely in the partial mole, there is a oocyte component, that is 23X is present, but there is two sperms which are fertilizing a single ovum. So it either could be XX or XY, that is XX of two sperms, or YY of two sperms, or X and Y of two sperms. So these two sperms will go and fertilize a single ovum. So there will be three sets of chromosomes. That is why it is 69XXX or 69XYY or 69XXY. So because there is both maternal and fetal component, sorry, maternal and paternal component, it will have both fetal parts and abnormal proliferation of the trophoblastic tissue. So there is triploidy, and that is why the fetus which is present will have all triploidy related features. So what are triploidy related features? The baby will have micrognathia and hydrocephalus, syndactyly, fetal growth restriction will be present, and there will be partial or focal hyperplasia of the trophoblastic tissue. But this is definitely abnormal because this baby cannot survive because of triploidy. So when in your early scans, if you're able to see the baby, but you're not able to identify that this is a partial mole, usually there are three criteria which is important. So this is called as a Newmoff's criteria of partial mole. What is Newmoff's criteria? There is placentomegaly with cystic spaces in the placenta, which is cystic spaces. Cystic spaces in the placenta seen on an ultrasound. So ultrasound criteria for partial mole, cystic places in the placenta and placentomegaly along with FGR, along with a empty gestational sac is present, but sometimes the fetal component is not uniformly seen. So that is also one of the criteria for a partial mole. So in your early pregnancy, if you're seeing the gestational sac is seen, yolk sac is seen, but the fetal pole is not very prominent, or there is a the fetus is present, but it is not corresponding to the period of gestation. So that is also, if there is early FGR, you have to rule out a molar pregnancy, especially if it is a partial molar pregnancy. So in this picture, you can see a syndactyly, and you can see there is focal proliferation of the trophoblastic tissue. Okay, so this is how you differentiate between a complete hydatidiform mole and a partial hydatidiform mole. And next, coming to the clinical features. So how does a woman with molar pregnancy present to you with? So this is also divided into how does a woman with complete molar pregnancy come to you with, and how does a woman with partial molar pregnancy come to you with. So usually the most of the clinical features are a result of a complete hydatidiform mole. But what about the partial hydatidiform mole? So usually in a complete molar pregnancy, you can see all these clinical features which I have mentioned here. But what about the partial hydatidiform mole? So usually the partial hydatidiform mole will present to you like a missed or an incomplete abortion. So there might be bleeding, pain, or sometimes missed abortion. You will not be able to either see. So Yashaswini, can you tell me what are the criteria for missed abortion?
If the gestation sac is more than 25 but the fetal pole is not present or not visualized, or if the crown rump length is 7 but there is no cardiac activity,
Mm,
then we'll call it as missed.
Next. Yes. Then if the G-sac is present, but there is no yolk sac or fetal pole, and you wait for 14 days and still there is no yolk sac or fetal pole, again it is a missed abortion. And if G-sac is present plus yolk sac is present, but there is no fetal pole, and you wait for 11 days and still there is no fetal pole, again you call it as a missed abortion. So these are the four important times where you diagnose a missed abortion, where gestational sac more than 25 without the presence of fetal pole or yolk sac is considered to be a missed abortion. If CRL is 7 but there is no cardiac activity, then again you call it as missed abortion. And if there is G-sac but there is no yolk sac or then there is no yolk sac or fetal pole, and you wait for 14 days, that is 2 days, but still there is no development of either of the two, again you call it as missed abortion. And if there is G-sac and yolk sac, but you wait for 11 days, and still there is no fetal pole, then again you call it as missed abortion. So this partial mole can present to you with components of missed abortion, like it presents to you like a missed abortion only when you do an evacuation and send it for histopathological examination, then you will get to know that it was a partial mole. So the gold standard of diagnosis of hydatidiform mole, or the definitive diagnosis of hydatidiform mole, is always after a histopathological examination. So though you have ultrasonic features, you have clinical features, or you have pathognomonic features like passing of grape-like vesicles, everything you have seen. But still, if you till the HP report comes, you cannot diagnose or you cannot definitely tell that it is a molar pregnancy. And sometimes incomplete abortion. Mother tells that she has passed some amount of products. You do a scan and there is some amount of RPOCs. And again, you will do an evacuation, surgical evacuation, and you will send for histopathological. And that will turn out to be a partial molar pregnancies. So usually a partial mole will always present to you with signs and symptoms of a missed abortion or an incomplete abortion. Whereas the complete hydatidiform mole will have all these clinical features. So what all clinical features I have written here? The main important clinical feature, 46% of women will present to you with vaginal bleeding. So the first trimester vaginal bleeding should definitely exclude molar pregnancy. And this usually the vaginal bleeding, what will happen? This tissue, the trophoblastic tissue, the abnormal tissue will get detached from the uterine surface and there will be some amount of bleeding. And also this trophoblastic tissue which is proliferated, this villi, sometimes they dissolve And this dissolving, after dissolving, this also can present you with like a bleeding. So it is described in literature as a prune juice, like grape color fluid, prune juice like bleeding. So this is also described. So you can go and search in net. Prune means it looks like a grape like color. So this type of abnormal vaginal bleeding due to the separation of the trophoblastic tissue from the uterine surface can also lead to bleeding in the first trimester. And this is the most common symptom the a woman with complete mole presents to you with. And uterine size also will be more than the period of gestation, and uterine size will increase in about 28% of the women. And here you have to understand 70% of the women, the uterine size is more than the period of gestation. 20% of the time, the uterine, no, sorry, the uterine size remains or corresponds to the period of gestation, and around 10% of the times it is less than the period of gestation. So usually if there is necrosed and the some of the material is already passed away, then you can see clinically, if you see and if you measure the height of the uterus, 70% of the times there will be increased in the size of the uterus. Around 20 times it almost corresponds to the period of gestation, and about 10% of the times it is less than the period of gestation. And I already showed you a picture of the pathognomonic feature of passage of vesicles per vaginum. So this is how there is passage of vesicles per vaginum. So this is the most specific and most pathognomonic feature of a complete molar pregnancy. And some women also present to you with pain abdomen along with bleeding PV. So if there is pain and bleeding in first trimester, you have to definitely rule out both ectopic pregnancy and molar pregnancy. So these are the two important things you have to rule out if the mother presents to you with both pain and bleeding in the first trimester. And because you already know that the placental tissue secretes beta HCG. So if there is increased beta HCG, there is highest risk of development of preeclampsia and hyperemesis gravidarum. So usually if the BP readings are high in the first trimester in a previously normotensive woman, you have to suspect molar pregnancy because of the increase or surplus amount of beta HCG. There might be preeclampsia features also. That is around 27% of the women with complete mole might have a coexisting preeclampsia. And also because of the increased beta HCG, there will be hyperemesis gravidarum. So all of you know that beta HCG goes and stimulates the chemoreceptor trigger zone in the brain. So this goes and causes excessive vomiting in the pregnancy. So excessive vomiting, especially you have to rule out molar pregnancy and multiple pregnancy, because in both the conditions there is surplus amount of beta HCG, which might be the main reason for hyperemesis. And you have to know that the beta HCG also resembles the alpha component of HCG, resembles TSH, FSH, LH hormones. So because of this, it also causes increased secretion of T3 and T4. So this might result in hyperthyroidism because the alpha subunit resembles these three hormones. This might also cause hyperthyroidism. So thyrotoxicosis in the first trimester, you have to rule out molar pregnancy, especially complete molar pregnancy. So this is associated in 7% of the pregnant mothers. And because of the presence of trophoblastic tissue, sometimes there might be embolization to different parts of the body, like chest, brain, and different other parts. So this also results in the embolization sequelae. So this is also common feature of complete hydatidiform mole. And also because of the increased amount of beta HCG, there might be formation of theca lutein cyst. So this is theca lutein cyst because of the beta HCG. It will go and stimulate the ovaries. So hyperstimulation of the ovaries will cause the excessive lutein cysts which are formed in the ovary. So this is called as theca lutein cysts. So all these clinical features are all more common in a complete hydatiform mole when compared to a partial hydatiform mole. So to repeat, in complete hydatiform mole, there is vaginal bleeding in 46% of the cases. The uterine size will be more than the period of gestation in 28% of the cases. The most pathognomonic feature is the passage of vesicles per vagina, and sometimes the woman will have, because of the distension of the uterus, there might be pain abdomen, and because of increased level of beta hcg, there is formation of preeclampsia, hyperemesis, hyperthyroidism, and theca lutein cysts. So this is mainly because of the hyperstimulation of the ovaries. So because of hyperstimulation of ovaries, there is presence of theca lutein cysts. And usually in the complete molar pregnancy, this trophoblastic embolization also is very common. So this trophoblastic embolization occurs, and that is why if the mother comes with sudden breathlessness or hemoptysis, or if she comes with sudden onset of seizures or paralysis, you have to rule out molar pregnancy. And if she tells, I got my UPT done, my scan is not done, now she comes with acute onset of any of these symptoms. So you have to do a scan, and if it is showing molar pregnancy, you have to do a chest X-ray or a CT chest to rule out pulmonary embolism. Or if she has seizures or any paralysis, there could be cerebral metastasis as well. So this is most common sequelae of GTN, but it can occur also in complete hydatiform mole. Whereas in a partial hydatiform mole, only the miscarriage like features will be present, like either a missed miscarriage or a incomplete miscarriage. Coming to the complications of molar pregnancy. So what are the complications of molar pregnancy is very important. So what might be the complications? So Yashaswini, can you tell me what can occur?
It can progress to malignant
Yeah. So development of
invasive
GTN. Correct. Next.
or these mole can get embolized to have
Yeah.
complications of
So there
embolization.
might be embolization, which results either in pulmonary sequelae or cerebral embolization is the most common. Yes, next.
Um,
There might be hemorrhage or bleeding. Bleeding in early trimester can occur. And sometimes there might be infection because of the passage of grape-like vesicles. There might be any ascending infections which might lead to sepsis also. And there might be perforation because of the over over distended uterus. The uterus might perforate also. So these are all sequelae, and there might be hyperthyroidism. So I already told you hyperthyroidism or the thyrotoxicosis can occur. Hyperemesis can occur in pregnancy. Preeclampsia can occur in pregnancy. Complications of theca lutein cysts like rupture of the theca lutein cyst, torsion of the theca lutein cyst, or internal hemorrhage in the theca lutein cysts, all this might occur. So these are the very important complications. So as she told, development of GTN, trophoblastic embolization to the lungs and the brain, and also it might lead to hemorrhage or infection, perforation of the uterus, hyperthyroidism, hyperemesis, preeclampsia, and certain complications of the theca lutein cyst. So what are the complications of the theca lutein cyst? There might be internal hemorrhage, there might be rupture of the theca lutein cyst, or the because of the heaviness of the ovaries, they might also undergo torsion. So these are the very important complications of molar pregnancy. Next, we
Some
have to.
sorry, ma'am, sorry to interrupt.
No,
Ma'am,
no.
if there is a disappearance of vessels, like if there's death of embryo and disappearance of vessels, should it not affect the trophoblastic proliferation?
No, the trophoblast. So there is the placenta and the fetus are there, and this vessels are between the placenta and the vessels. So this is a tumor. So it will have neovascularization. So it is not supplying the blood to the baby or the embryo, but internally it has neovascularization. So the trophoblastic tissue is not affected because it is continuously proliferating and it has neovascularization. That is why on USG, there is, if you put a Doppler, there is high vascularity of the trophoblastic tissue. I will show you the images. So there is neovascularization of the tissue, but the blood supply is not effective to the baby. That is why there is disappearance of the baby, but the trophoblastic tissue still remains.
Okay.
Okay. So you have to understand that the very important differences of a complete mole and a partial mole. So almost I have told, but this is like a revision. So the karyotype in complete mole, as I told you, it's a diploidy. So it could either be 46XX or 46XY. If it is a partial mole, it is triploidy. So it is 69XXX or 69XXY. Coming to the pathology, in a complete mole, the fetus is absent. But in a partial mole, the fetus is present. In a complete mole, the villus edema or the trophoblastic villi will have diffuse trophoblastic proliferation. But in a partial mole, there is focal trophoblastic proliferation. And in a complete mole, the trophoblastic proliferation will be variable and it might be marked in some cases. That is why there is huge distension of the uterus even in earlier gestations. But in a partial mole, it is usually focal and very minimal. And sometimes we will not be able to get to know in the antenatal or in the evacuation period. Only after histopathology, we will be able to know that it is a partial mole. So it could be very focal and minimal proliferation of the trophoblastic tissue. And the very important thing is the P57 KIP2 immunostaining. So there is immunohistochemistry. So because of the maternal component in partial mole, so this P57 KIP2 is expressed. So it is paternally imprinted but maternally expressed. So if it has maternal component only, this P57 KIP2 will express. So if you do an immunostaining and if you want to recognize whether it is a partial mole or it is a complete mole, you can do a immunohistochemistry, that is the dye you can do, and to recognize whether it is positive or not. So if it is positive, definitely it is a partial mole. But if it is negative, it is called a complete mole. And usually the typical just diagnosis, the molar complete mole will have all clinical features like hyperemesis, preeclampsia, and increased uterine size, vaginal bleeding. All these are present in a complete mole. But in partial mole, it could be just a reflection like a either a incomplete abortion or a missed abortion. And post-molar malignant sequelae, that is development of GTN, is more common in a complete mole, that is 15 to 20% of the time. But in a partial mole, it is less common, that is 2 to 4%. But when we, and this is the same thing which I have told, but you have to understand that P57 immunostaining is a very important thing and it is coded for P57. It is a cell cycle inhibitor. So it is, this word is very important. It is paternally imprinted but expressed from the maternal allele. So if there is no maternal allele, this expression will not result. So only in partial moles, the maternal genetic material is present. That is why this P57 immunostaining is present only in a partial molar pregnancy. Excuse me. So when you get the histopathological examination, And if you are not able to differentiate whether it's a complete mole and partial mole, you have to do the immunostaining. So you can see whenever they have done, here see there is diffuse proliferation of the trophoblastic tissue. Everywhere there is proliferation. But here there is only in the margins, there is slight proliferation. There is no proliferation inside. So there is focal proliferation in the partial mole. But here to see in P57 immunostaining, there is no staining of the trophoblastic cells. But here you can see all these brown color. So it is stained with P57 positive. So in a partial mole, because of the presence of maternal allele, this P57 KIP immunostaining is positive. Sometimes you will not know whether it is a hydropic fetus or it is a partial molar fetus. So what is a hydropic fetus? It is biparental. So this in a complete mole, it has no maternal component, only paternal component. And if you do a karyotyping, it will be 46XX or 46XY. So it is a diploid pregnancy. If you do a karyotyping in partial mole, it will be either 69XXY or 69XXX or 69XYY. It is triploidy. So here it was diploidy in complete mole and it was diploidy in partial mole. But in a hydropic fetus, there will be diploidy, but it will be biparental. So it will be both maternal component and paternal component. So because it has both maternal and paternal, this also will have P57 immunostaining positive. So based on the karyotyping and the histopathology, you will know whether it is a complete mole or a partial mole or a hydropic fetus. Okay, understood? So if you have a diploidic picture along with P57 positive, obviously it is a hydropic feature. But if you have a diploidy but P57 is negative, it is a complete molar pregnancy. Yashaswini, can you please repeat?
Yes, ma'am. If there is in complete mole, there is 46XX or 46XY. Along with that, in complete mole, because there is, P57 will be absent because there is no maternal component. But in partial mole, it is usually triploidy, where there is 69XXX or 69XXY or 69XYY. But here, P57 marker will be positive because it contains maternal. But in case of in case of hydropic changes, they will be diploidy where there is 46XY or there will be maternal and fetal component, and therefore it will stain positive for P57.
Yeah, good. So hydropic fetus also will have the same like the on ultrasound, or if you see after the delivery, if you see the baby, it might look like a partial molar pregnancy. But only when you do the immunostaining of the placental tissue, you will understand that it was a hydropic fetus and not a complete mole. So if you do both karyotyping and if you do a P57 immunochemistry, then only you will differentiate between a complete mole or a partial mole or a hydropic fetus. Understood? Mary madam?
Yes, ma'am. Yes, ma'am.
Or should I repeat once again?
No, ma'am.
Okay. So if you do a karyotyping, you will know you will know the ploidy status. If you do a histochemistry, you will know whether the genetic material is both paternally derived and maternally derived, or it's only paternally derived. So based on these two things, we can derive that it is either complete or partial or a hydropic fetus. Okay. So whenever the patient comes with all these clinical features, you have to do some investigation. So before going into evacuation or doing any management, you have to basically do some basic investigations, and what is its importance is very important. So what are the basic blood investigations you have to do? So you have to do a complete blood count. So you have to do a complete blood count. You have to do a blood grouping plus RH typing. You have to do serology. You have to do thyroid profile. You have to do an LFT, and you have to do an RFT, and you have to do serum electrolytes. So all these are very important for our evacuation purpose. So these are the very important blood investigations you have to do. CBC, blood grouping and RH typing, serology, thyroid profile, LFT, RFT, and serum electrolytes. So these are the important blood investigations to be done. And we have to do a chest X-ray. So whenever there is suspicion of complete mole, or if you have already diagnosed it on ultrasound, you have to do a chest X-ray to rule out pulmonary embolism. So as I already told, the trophoblastic tissue has a chance of embolization to the lungs. So that's why you have to rule out this, and you have to do a pulmonary, so you have to do a chest X-ray to rule out pulmonary embolism. So if there is any presence of pulmonary infiltrates, then it is definitive, and you have to do a CT chest to confirm. And this does not require anything. So unless it is hampering uh, the oxygenation of the mother, it's not, you can just conservatively manage and by giving chemotherapy. But if she acutely, if she requires something, and you have to do a thoracotomy to take out the tumor. So that is only in gestational trophoblastic neoplasia, you have to do a thoracotomy. But for generalized metastasis, chemotherapy will suffice. But in a benign condition, you need not do anything. You can just manage her conservatively. And also, beta HCG is very important. So, pre-evacuation beta HCG is very important. So, you should know whether it is less than 1 lakh or whether it is more than 1 lakh. So, usually in a complete hydatidiform mole, it is more than 1 lakh. But in a partial hydatidiform mole, it is less than 1 lakh. But this 1 lakh is the criteria where if it is more than 1 lakh, the chances of development of gestational trophoblastic neoplasia is more. That is why more than 1 lakh, you have to be careful in the post evacuation surveillance. So that is why our pre-evacuation value of beta HCG is very important, and we have to not miss doing a beta HCG value. And also, to differentiate between a complete molar pregnancy or a partial molar pregnancy, we have to be doing the ultrasound with Doppler. So this is a picture which shows the ultrasound picture of a complete mole. So we can see a solid internal echoes with numerous small anechoic spaces. So it is called a classical snowstorm or a granular appearance. So this is because of the multiple placental trophoblastic vesicles. So this has no fetal part. So you can observe in this. So this is the uterus. So inside the uterus, there is only presence of tissues and numerous cystic spaces. So uh, this is a appearance called as snowstorm appearance, which is seen on an ultrasound. So this is due to the multiple placental vesicles. But in a partial molar pregnancy, there is cystic placenta and there is presence of a fetus. So there is a fetus, but there is also presence of cystic spaces in the placenta. So either there can be focal or cystic places in the placenta. Placentomegaly will be there. And if the fetus is there, the fetus will usually be growth restricted. So this is the ultrasound features of a partial mole. So in a complete mole, there will be just the proliferation of the trophoblastic tissue. But in a partial mole, there will be both fetal component and the placental hyperplasia. So both will be present. So this is the ultrasound picture, and on an ultrasound in a complete mole, usually we can see this snowstorm appearance. So this is a beautiful, not so strong, spoke wheel appearance. Spoke. So it is like a wheel. So it is like this. So multiple cystic spaces in the placenta, in the ovary, sorry. In the ovary, there are multiple cystic spaces. So these are the theca-lutein cysts. So on a gross picture, you can see on table, intra picture, you can see the uterus. Uterus is here. These are the fallopian tubes, but largely enlarged ovaries with multiple theca lutein cysts. So this is an ultrasonic picture of theca lutein cysts, and they are multiloculated and they have a honeycomb appearance or a spoke wheel appearance. It is called. And this theca lutein cyst usually persists for about 8 weeks after evacuation. So within 2 to 4 months, they go back to its routine size or a normal sized ovary. So to return back to the normal size, on an average, it takes about 8 weeks, that is 2 months, but sometimes up to 4 months. So after evacuation, the theca lutein will go back to its normal size. You need not do anything. You need not do oophorectomy, or you need not do cystectomy, or you need not do drainage. You need not do anything. After evacuation, because of the normalcy of the beta HCG, the secretions will stop and the stimulation will stop, and they will go back to its normal size by 8 weeks post evacuation. So 8 weeks, the normal uh, ovary will return, and it will, on an average, 2 to 4 months it is described. Okay, so this is the gross appearance and this is the radiological appearance. And as I already told, on Doppler, there will be high velocity and low resistance index. So pulsatility index and resistance index will be low, mainly because of the increased vascularity and neovascularization inside the trophoblastic tissue. So in this, you can see so much vascularity. The entire products inside the uterus are highly vascular. So this proves that there is lot of neovascularization which is happening. So this is mainly the uterine vessels will invade and cause the blood supply to the trophoblastic tissue. So there will be high velocity and low resistance indices, and high vascularity will be present of the trophoblastic tissue. So this also has to give you a suspicion that it could be molar pregnancy. Next, I told you that there might be some elevation of beta HCG. So usually the beta HCG, if there is more beta HCG, the level of beta HCG should be checked. So pre-evacuation, you will check the beta HCG, and if it is more than 1 lakh, it is called a high risk mole. So it is called high risk mole. Why is it called high risk mole? Because the chances of development of GTN is high. So because of increased risk of GTN, you call it as a high risk mole. And this quantitative estimation and dilution, I will discuss at the end. Okay. Why is it important? Why you have to dilute? So there is something called as hook effect. So shall I tell it now? Okay, I will tell it now only. So what happens whenever there is increased beta HCG? Obviously, you know there is molar pregnancy. There is increased secretion of beta HCG hormone. So it is a hormone. So whenever there is high amount of beta HCG, what will happen? It will oversaturate. You will do a card test. So you will do an UPT. So what will happen? You will put the urine, and because of the increased amount of beta HCG in the urine, what will happen? The antibodies which are present in the card will get oversaturated. That time it will give a false negative result. So it is positive, but still it is giving a negative result. So UPT will be negative, but then you do a serum beta HCG, it will be very high. So what would be the main reason why urine pregnancy test or why this card test was negative? Because there was oversaturation of the antibodies or the assay which was present on the card. So if you have done a sandwich ELISA test, so there is over amount, the antigen is so much that the antibodies are oversaturated. So that means it gives a negative effect. So that time what we have to do, we have to dilute that urine. So if you dilute and then you see and it is still positive, that means it is a beta HCG positive case. So if you dilute by 100 and if it is still causing the presence of beta HCG, or if it is UPT positive, it is either seen in normal pregnancy or a molar pregnancy or a multiple pregnancy. If you are diluting by 200 times, you can see the positive result in molar pregnancy and multiple pregnancy due to the surplus amount of beta HCG. but you're diluting 300 times and still there is positivity, then it is in the molar pregnancy. Okay. So even if you dilute it by 300 times, still if it is causing positive, then it is definitely molar pregnancy, because that is the level of beta HCG which is present in molar pregnancy. In a normal pregnancy, it will be around 100 to 200, but in milli international unit per ml, but in molar pregnancy it will be as high as 1 lakh. So there is so much difference in a normal beta HCG level to a molar pregnancy level. So though you dilute it so much, still if it is positive, then definitely it is an estimate of molar pregnancy. So sometimes even if the beta HCG is so high, if UPT is showing negative, that means it is called a hook effect, where there is presence of surplus amount of beta HCG, which is causing the oversaturation of the antibodies which are present in the assay, and that is why it is showing negative. That time you have to do serial dilution and repeat UPT, or you can do a serum assessment of beta HCG. Understood? You understood what is hook effect? Okay. Then you can do a chest X-ray abdomen to rule out a negative fetal shadow, to differentiate between a complete mole and a partial mole, and a chest X-ray to rule out pulmonary embolism, and CT or MRI if you want to do rule out a distant metastasis. So if she comes with paralysis or if she comes with seizures and you want to rule out brain metastasis, obviously you have to do a CT or MRI brain. Okay, to detect distant metastasis. So these are the different kinds of investigations. You have to do blood investigations, ultrasound, and then you have to do a chest X-ray. And depending on any clinical features, or if you want to rule out distant metastasis, you have to do a CT or MRI. And serial beta HCG, pre-evacuation beta HCG is important. And if you want to dilute and see, you can see the quantitative estimation of beta HCG, which is the highest in molar pregnancy. Coming to the management. So the gold standard management of molar pregnancy is suction evacuation. So there is nothing other than this management. So in a complete hydatiform mole, what is the management? You have to do investigations and manage by doing a suction evacuation. So what are the principles of suction evacuation? So there is a GTG on molar pregnancy. So this GTG has told that there are some principles of suction evacuation. So what is it? It's usually to be done under ultrasound guidance. So always the evacuation should be done under USG guidance. And you have to not do continuous, you have to not remove the trophoblastic tissue with ovum forceps or whatever. It is always better you do a MVA, or you introduce the Carman's cannula and you connect it to the electronic vacuum suction. Either you can do a manual suction, manual vacuum aspiration, or a suction evacuation with electronic manual an electronic vacuum aspirator. So either you can do MVA or EVA. So EVA is electronic vacuum aspiration. So that is, you have to prepare the woman. So get all relevant investigations, and you have to, it can be done either by giving a IV sedation, that is general anesthesia or IV sedation, or it can be performed by giving a local, that is regional anesthesia. You can do under spinal, or you can do an IV sedation, or you can give general anesthesia. Some people, if it is very small, like 8 weeks, 9 weeks, you can do even a paracervical block you can give, and you can evacuate the molar pregnancy. So suction evacuation, it should be done either in general anesthesia or IV sedation or regional anesthesia. If it is less than 10 weeks, you can either use a local anesthesia, that is paracervical block. And serial dilatation of the cervix should be done with a serial Carman's cannula. So Carman's cannula 6, 7, 8, 9, 10, based on the gestational age, the number of the Carman's cannula should be chosen, and you have to connect it to either the manual vacuum aspirator, MVA syringe, or you can use, and you can directly connect this Carman's cannula to the suction apparatus. and then all the entire molar components or the entire trophoblastic or villus tissue will be suctioned. So once the suction is complete, you should do a sharp curettage. It's not you can. After the suction evacuation, it should be followed by a sharp endometrial curettage. So this sharp curettage, once, it should not be multiple times, you need not do curettage. One sharp curettage on all walls of the uterus. So this is indicated to prevent the invasive disease. So the suction evacuation followed by a sharp endometrial curettage. So what about role of cervical preparation? So usually before doing a MVA or a EVA, do we need to use a misoprostol? So before they used to tell no need to use any prostaglandins or oxytocin, but present consensus is you can use just before the evacuation. So if you're planning for an evacuation, yeah, at least 1 to 2 hours, you can either use misoprostol or you can use any other agents. So this before they used to tell that this will increase the risk of embolization and invasive disease, but the present consensus is you can use. So role of cervical preparation, it can be safely used before evacuation. What about the role of oxytocin? So what happens whenever you put a Synto drip, the uterus starts contracting. So if the uterus contracts, there might be distal metastasis or there might be trophoblastic embolization was the theory which was proposed. Still, that holds good. So usually we need not start oxytocin pre-evacuation. It can be started post-evacuation for contraction of uterus and stoppage of bleeding. But if there is any acute bleeding, or if the mother is deteriorating, if the vitals are not stable, or if there is acute onset of vaginal bleeding, even before or during the time of evacuation, if there is increased bleeding, you can start a oxytocin drip. Otherwise, no need to routinely start oxytocin drip during the time of evacuation. You can put 10 units of oxytocin post evacuation just to contract the uterus and to prevent hemorrhage after evacuation. But pre-evacuation or during evacuation is only when there is acute bleeding. If there is no acute bleeding, no need to start Synto drip. And what about repeat curettage? So once you have done curettage, and if the mother presents to you with again repeated episodes of vaginal bleeding, or if the ultrasound is showing any retained evidence of molar tissue, only then we have to do a repeat curettage. Otherwise, no need to do a repeat curettage. So firstly, do all investigations, prepare the mother, ask her to void urine, make her lie down in dorsal position or lithotomy position, give her general anesthesia or IV sedation or regional anesthesia or paracervical block, do serial dilatation with a Carman's cannula, not with the Hagar's dilator, always with the Carman's cannula, and you can either do a manual vacuum aspiration or you can connect it to the electronic vacuum aspirator and aspirate all the trophoblastic tissue, and then you have to do a sharp check curettage, and everything should be done under a ultrasound guidance, mainly to prevent perforation and to prevent retained products. And what is the role of cervical preparation? 1 to 2 hours before, you can give misoprostol. There is no risk of embolization. What is the role of oxytocin? Only if the mother is bleeding or only if there is acute hemodynamic compromise, then only you have to start oxytocin. Otherwise, no need to start pre-evacuation. But once evacuation is complete, we can give a oxytocin drip for uterine contraction to prevent excessive bleeding. And what is the role of repeat curettage? Only if there is any evidence of retained tissue inside the uterus, or if she has on and off irregular bleeding, only then we have to do a repeat curettage. Otherwise, no need to do a repeat curettage. So what about the role of hysterectomy? So when do you want to do a hysterectomy in the cases of GTD? So what about hysterectomy? Yashaswini, do you have any idea when hysterectomy is done?
It is invasive.
Hmm?
if it is invasive or if during the procedure, if there is uncontrolled
Yeah, if
bleeding,
there is
not
an
controlled by
invasive
medical
disease,
also, or after evacuation, if there is severe bleeding which is not getting controlled by any medical management,
yeah. So first thing, in cases of
or
high risk moles. So I told you, if she's already completed family and there is a risk of high risk mole. So if the beta HCG is more than 1 lakh, if the maternal age is more than 40 years, and if there is presence of theca lutensis, and there is one more, and if the uterus size is larger than the period of gestation. So these are the four criteria to call it as high risk mole. If the uterine size is more than the period of gestation, maternal age is more than 40 years, if she has the pre-evacuation beta HCG more than 1 lakh, and if there is presence of theca lutensis more than 6 centimeters. So these cases, it's called as a high risk moles. And in cases of high risk moles, and if you don't want, if the mother is not compliant to get a serial beta HCG follow up, and you think that she has a high risk of development of gestational trophoblastic neoplasia, definitely you can do a hysterectomy. So for high risk moles is the first indication of hysterectomy only in completed family cases. And as you told, when there is uncontrollable bleeding. So when you are not able to control the bleeding and there is high bleeding immediately after evacuation, and if there is any suspicion of perforation,
perforation.
you open and you see there is a perforation and you cannot repair it, then also you have to go ahead with uh, hysterectomy. And as you already told, invasive disease and some GTNs like persistent placental site trophoblastic tumor and epithelioid trophoblastic tumor. So these are the two conditions, and this is a type of gestational trophoblastic neoplasia which is chemo resistant. We cannot give methotrexate or dactinomycin in these cases. So these GTNs are not sensitive to chemotherapy. So even those cases where histopathologically proven cases of placental site trophoblastic tumor or epithelioid trophoblastic tumor, you have to go ahead with hysterectomy. So high risk moles, uncontrollable bleeding, if there is any suspicion of perforation, and if there is any invasive disease such as persistent placental site trophoblastic tumor or epithelioid trophoblastic tumor, you have to go ahead with hysterectomy. So what is the role of prophylactic chemotherapy? So you need not use prophylactic chemotherapy in all molar pregnancies. Only in some conditions you have to start chemotherapy post evacuation. So you will do a suction evacuation and then you will follow it up with doing a chemotherapy. So what are the conditions? Usually if there is GTN with suspected lung or GI or brain or liver metastasis of more than 2 centimeter, and sorry, if there is any metastasis and if lung metastasis is more than 2 centimeter, we have to start chemotherapy. And if you have taken a histopathological examination and if it is a choriocarcinoma, then also you have to start on chemotherapy. And if there is any heavy vaginal bleeding or any other GI or intraperitoneal bleeding, then also you have to start chemotherapy post evacuation. And any other distant metastasis like pulmonary or vulval or vaginal metastasis, you have to start. And if there is any rising HCG in two consecutive serum samples. So first day you will repeat, again on the 7th day you will repeat, and again on the 14th day you repeat. If the beta HCG is raising, that it is, if it is more than 10% raise on the first day, 7th day or 14th day. So today you have done, 1 week later you repeat, it is and 2 week later you repeat, the beta HCG is more than 10% increasing. So if it is in that increasing trend in the first two consecutive samples, then also you have to start prophylactic chemotherapy, that it is a progression to GTN. And if the HCG is more than 20,000 even after 4 weeks of evacuation, then also you have to start chemotherapy. And if there is HCG plateau means if there is less than 10% decrease in beta HCG value on 7, 14 and 21 days, that is in 3 consecutive samples or in 3 weeks, that is first week, second week and third week, there is less than 10% decrease that of the beta HCG and it is in the play 2 level, then also it is suspicious of progression to GTN and you have to give or start chemotherapy. And even after evacuation, if there is raised beta HCG till 6 months, it is also one of the evidence of persistent trophoblastic disease. So if there is persistent trophoblastic disease, it is an indication for chemotherapy. So these are all different kinds of indications post evacuation to give prophylactic chemotherapy. So what is the prophylactic chemotherapy? It is single methotrexate course. So how much is the methotrexate dose? 1 to 1.5 mg per kg on first day, third day, fifth day and seventh day. And you will add folinic acid on second day, fourth day, sixth day and eighth day. So this is the single course of beta HCG which is given in cases of prophylactic chemotherapy. Okay. Next, how do you follow up beta HCG? So this is a very important topic and it requires special attention. So we have to always follow up for beta HCG is very important post evacuation. So am I clear till now?
Yes.
Are you feeling sleepy? No?
No, ma'am.
Okay. So follow-up of beta HCG, you have to know because the chances of risk of persistent trophoblastic disease is common after molar pregnancy. So we have to always rule out the possibility of persistent trophoblastic disease after suction evacuation in a normal cases of molar pregnancy, either complete molar pregnancy or partial molar pregnancy. 1 second before this, here, I told you in complete hydatiform mole, the main management is the suction evacuation. In partial hydatiform mole, if you have measured the fetal size and the fetus cannot come through suction, so suction apparatus, you cannot, it is a very small Carmen's cannula and if the fetus is big, you cannot do a suction evacuation. So that time you have to always do a medical management. So you have to do a medical management by giving misoprostol and after the complete expulsion of products of conception, we have to do a sharp curettage. Okay. So this is the management in partial hydatiform mole. This I forgot to tell. So in a complete hydatiform mole, obviously it is grape-like vesicles which can be easily removed by suction evacuation. But in a partial mole, if the fetus size is small and if it is less than 7 weeks and all, you can evacuate it through suction apparatus. But if the fetus size is more, then you cannot do a suction evacuation. That time you have to do a medical abortion or medical management. Okay, and post evacuation for both suction evacuation in complete and medical abortion, we have to do a sharp check curettage, which is very important. So role of hysterectomy, I told you. Role of prophylactic chemotherapy, I told you. Now coming to follow-up. So why follow-up is important? In molar pregnancy to rule out the persistent trophoblastic disease. So persistent trophoblastic disease has to be diagnosed and managed and this is very important. Okay. So the follow-up of beta HCG varies between a complete hydatiform mole and a partial hydatiform mole. So usually we do a pre-evacuation beta HCG. So once pre-evacuation beta HCG is done, we have to do the suction evacuation. So once suction evacuation is done, followed by this, sorry, 1 second. Sorry. Yeah. So follow-up of beta HCG post-evacuation. So this is important for ruling out persistent trophoblastic disease. So persistent trophoblastic disease has to be ruled out. So we have to do the follow both in complete hydatidiform mole and partial mole. So how do we do? So firstly, we would have done a pre-evacuation beta HCG. Then this is followed by suction and evacuation. Once we do the suction and evacuation, on the day of suction and evacuation or the next day, we have the basal beta HCG level. So that is post evacuation beta HCG. So once this value is obtained, for every week, we have to repeat beta HCG. So every week until the beta HCG is less than 5 milli international unit per ml. So every week you repeat, and if the beta HCG value comes back to normal within 56 days, you have to repeat every month till 6 months post evacuation. If the beta HCG value does not come to normalcy within 56 days, that is 8 weeks, we have to repeat beta HCG every month till 6 months from date of normalization of the beta HCG. So I will repeat again. So today we have done evacuation of the molar pregnancy. So tomorrow we have got and done a serial beta HCG. So we have repeated the serum beta HCG tomorrow. So once we have repeated the serum beta HCG, we have got a basal level. For example, it is around 10,000. So weekly we have to repeat the beta HCG. So if this weekly repetition of beta HCG has come back to normal, that is less than 5 milli international units per ml within 56 days, that is 8 weeks, then every month you have to do till 6 months from the evacuation date, that is from today, that is 10th May 2025, till next 6 months monthly we have to repeat. But if the beta HCG value has not come back to normal within 56 days, that is 8 weeks, we have to serially go and do every week till it comes back to normal. So for example, 10th week it will come to normal. So from 10th week, from the day of 10th week, for example, if the 10th week falls on August 10th, so from August 10th, the next 6 months monthly beta HCG follow up we have to do. So if it comes back to normal within 8 weeks, it is monthly interval from the date of evacuation. But if it does not come back to normal within 8 weeks, then monthly follow up till from the date of normalization of the beta HCG. So this is the golden rule of follow-up for complete molar pregnancy. But whereas in the partial mole, we have to do weekly follow-up till it comes back to less than 5 milli international unit per ml. Then two consecutive values, consecutive, I forgotten consecutive spelling. Consecutive values. If it is two consecutive values is normal within 4 weeks, then you can stop. So partial is easy. So today I have done the evacuation. Tomorrow the value is 10,000. After 2 weeks, it's come back to normal. So after 2 weeks, it is normal. Once after 4 weeks of that, you do. And if it is normal, you can stop. Understood? So today I have done, that is on 10th May I have done. By 30th May, it is normal. So after you will do on 30th June, and if it is normal, it is enough. So two consecutive values 1 month apart, if it is normal, then you can stop the follow-up in case of partial molar pregnancy. So what is the median time of resolution? In a complete molar pregnancy, the beta HCG comes back to normal by around 7 weeks. But in a partial mole, it comes back to normal by around 9 weeks. So ninth week, it's come back to normal. Ninth week, it's come back to normal. After that, after 1 month, you will repeat, and if it is normal, you need not do any other further follow-up. But for a complete mole, within 8 weeks, if it is come back to normal, you have to do monthly follow-up for 6 months. If it is not come back to normal till 8 weeks, then you have to do monthly follow-up from the date of normalization. So this is how we do a follow-up of beta HCG. Mary madam, can you please repeat how to do follow-up?
In a complete whole pre-evacuation, the on the day or after that, we are going to basal beta HCG level is done, and it is followed every month till 6 months for post evacuation. That is up to 56 days. If it is less than 5 millunits per ml, if it is after 56 days also, if it is high, then we are going to repeat it every month till the date of from the date of normalization. And in partial mode, weekly follow-up till 2 consecutive normal values till 4 weeks, and we'll stop. Within 4 weeks, and we'll stop.
So I will repeat once again. This is very important. Complete mole, weekly, you have to do the follow-up. So if this weekly follow-up, by 8 weeks, if it is come to normal, then you have to start monthly follow-up for 6 months. And if it is less than 8 weeks, from 6 months from post-evacuation. If it is more than 8 weeks, 6 months from the date of normalization. In partial mole, weekly follow-up you have to do. And once it is normal, if it should be repeated after 1 month, and if that value also is normal, you can stop. So two consecutive values, 1 month apart, you can stop once it is normal. Okay, so median time of resolution for a partial mole is 9 weeks, and for a complete mole it is 7 weeks. So usually if you are following up, so what is it? What is normal? So usually by every week or every 2-3 weeks, the beta HCG value should fall. But if it is plateauing or if it is rising, then you have to have a suspicion of development of persistent trophoblastic disease or development of gestational trophoblastic neoplasm. So the main high risk moles are at a higher chances of development of gestational trophoblastic neoplasia. And I've already described that if the uterine size is larger than gestational age, if the pre-evacuation HCG is more than 1 lakh, if there is presence of theca lutensis more than 6 centimeter, or if the age of the mother is for more than 40 years. So these are the criteria for high risk moles, and they are the high risk population who are at a risk of development of GTN. So when you are doing the post-molar follow-up, if there is plateau of the beta HCG, lasts for at least 4 measurements over the last 3 weeks, that is on the 1 or 7, first day, day 7, day 14, and day 21. In those 3 weeks, if there is plateau, means if there is less than less than 10% decrease of the beta HCG value, it is called as plateau. So that is also one of the criteria for development of GTN. If there is raise of the beta HCG level more than 10%, in the 3 consecutive weekly measurements in the period of 2 weeks, that is first day, 7th day, and 14th day. If there is more than 10% rise, instead of falling, it is raising. Then also there is a probability of GTN. And if there is persistent high level of beta HCG, even after 6 months post evacuation, then also you have to suspect persistent trophoblastic disease. And if there is any histological diagnosis of choriocarcinoma, then also you have to suspect gestational trophoblastic neoplasia. So this is FIGO criteria for development of GTN. So either plateau in the 3 weeks or rise in the 2 weeks or persistence of high beta HCG in 6 months, or if there is histologic diagnosis of choriocarcinoma. So these 4 criteria is the FIGO criteria of development of persistent trophoblastic gestational trophoblastic neoplasm. Next, contraception. So what is the most important contraception advice you have to give to the mother? So obviously, during the follow-up of beta HCG, you don't want her to become pregnant because you will not know whether it is because of the new pregnancy or it is because of the persistent trophoblastic disease or development of GTN. So that is why you don't want to her to become pregnant until that period of follow-up. So what contraception you will advise? So till the beta HCG becomes normal, HCG normalizes, that is less than 5 milli international per ml, she has to use some method called barrier method like condom, diaphragm, anything. After beta HCG is normalized, she can use hormonal contraception like OC pills. And IUCD should not be used because GTD has a higher risk of perforation. So that is why we do not advise the mother to go for a copper T or Mirena insertion post evacuation. So post evacuation, you have to ask her to have some method of contraception. So what method? Till beta HCG normalizes, barrier method. After beta HCG normalizes, OCPs are the ideal methods of contraception. But if she has completed family, you can go for permanent sterilization also. But intrauterine contraceptive device is not recommended until follow-up is completed because of the risk of perforation. So we do not insert a copper T or Mirena. So what about the follow-up in subsequent pregnancy? So some people used to tell that subsequent pregnancy also there might be risk of GTN. So the product should be sent for histopathology if it results in abortion, or placenta should be sent for histopathology, all this. But present consensus tells that there is no requirement of follow-up in subsequent pregnancy. So unless there is suspicion of molar, if there is no suspicion of molar, no need to follow up in the subsequent pregnancy. So present GTG tells that there is no requirement of follow-up in subsequent pregnancy. Okay. So some things I want to tell about beta HCG. So there is HCG. So that is human chorionic gonadotropin, which is secreted by syncytial trophoblast of the placental tissue. So there are two chains, the alpha chain and the beta chain. So beta chain is specific for pregnancy, and alpha chain resembles thyroid stimulating hormone, luteinizing hormone, and follicular stimulating hormone, even CRH, that is corticotropic releasing hormone. So all these 4 hormones, the alpha chain, subunit chain will resemble, but beta subunit chain is specific for pregnancy. So this beta HCG is secreted by syncytiotrophoblastic cells. So there is alpha chain and beta chain. Alpha chain has 92 amino acids, beta chain has 155 amino acids, and this beta HCG is secreted by syncytiotrophoblastic. And already I told you what is hook effect. So when there is excess of beta HCG, for example, in molar pregnancy, the assays get hypersaturated or oversaturated, and sometimes they might give a false negative result. You have to know what is a phantom beta HCG. So sometime when there is presence of heterophilic antibodies in the maternal serum, what will happen? You do a serum beta HCG. there will be you will do a serum beta HCG assay, or you will do a urine UPT test. What will happen? Because of the presence of heterophilic antibodies, this might resemble the beta HCG. And then if you do the assay, it will come positive. But actually, there is no high level of beta HCG. That is why it is called as phantom beta HCG or false beta HCG. So how will you know whether it is positive or not? You have to dilute the serum or urine. So even after dilution, if it comes positive, then it is true beta HCG. If after dilution, if it does not come positive, it is called as phantom beta HCG. And very important thing is the doubling time of beta HCG. What is doubling time, Yashaswini? So usually, to rule out whether it is an intrauterine pregnancy or an ectopic pregnancy, we do something called as a doubling time. So we tell if today the beta HCG is 1000, for it to double, that is 2000. How much time does it require? So if 2000 to become 4000, how much time does it require? So usually in UG textbooks, they tell the doubling time of beta HCG is 48 hours, but that is not true. So usually the doubling time of beta HCG ranges from 2 to 7 days. So how does it change? So as the pregnancy advances, the doubling time increases. So if the beta HCG value is less than 1500, the doubling time will be between 31 to 72 hours. If it is between 1500 to 6000, the doubling time will be 72 to 96 hours. That is 2 to 3 days. If the beta HCG is more than 6000, the doubling time will be more than 4 days. That is more than 96 hours. So the range of doubling will be between 2 to 7 days. That is 48 hours to 7 days. So what is doubling? It is the beta HCG value to be multiplied by 2. Okay, so that is doubling. So usually normal doubling occurs in a intrauterine pregnancy, but this doubling will not occur in a ectopic pregnancy. So to rule out between an intrauterine and ectopic, so for example, today's value is 1500. You repeat the value after 2 days. It should have become 3000. But if it is still 1800, you have to rule out the possibility of ectopic pregnancy. So usually in an intrauterine pregnancy, normal doubling occurs. But ectopic pregnancy, this doubling will not be there. So the beta HCG should rise at least by 63% to call it as normal intrauterine pregnancy. So if it is rising more than 66%, you tell it should be an IUP, that is intrauterine pregnancy. If it is not raising beyond 33%, you have to have high suspicion of ectopic pregnancy. So this is the importance of doubling time. And if it comes to beta HCG, you have to understand what is hook effect and what is phantom beta HCG. Next, what are the present guidelines? So I told you there is a GTG guideline which was amended in September 2020. That is GTG number 38. So this guidelines give us a brief consensus about how to go about in the management of molar pregnancy.
Last.
What?
No.
Mary madam? Okay.
Hello?
So what does the GTG tell? So I told you clinically, what is the clinical presentation? Even GTG tells that the complete hydatidiform mole presents with abnormal vaginal bleeding, the presence of preeclampsia, hyperemesis, or increased uterine size. All these are the clinical theca lutensis. All are presentations in complete mole. Whereas a partial mole, they present to you as a missed abortion or a incomplete abortion. Next, definitive diagnosis is only after a histopathological examination. So the GTG clearly tells that to diagnose molar, the definitive diagnosis is by HPE. And how do you remove? You remove by a suction evacuation followed by a sharp uterine curettage. And should anti-D be given? Yes. 300 microgram of anti-D should be given in molar pregnancies. But ideally speaking, it should be given only if fetal RBCs are present. So where is the fetus present? Partial or complete?
Partial.
Partial. So ideally it should be given only in a partial hydatidiform mole. But to know whether it is a partial or complete, we require histopathological examination. So that will take about 5 to 6 days. So you cannot keep waiting to know whether it is a complete or partial mole. So that is when you have to give it on a routine basis within 72 hours of evacuation. Either it is partial or complete. To be on a safer side, you give off anti-D within 72 hours of evacuation. So how much anti-D you have to give? 300 microgram. Is
Irrespective of
cervical
the
preparation?
gestational age,
Huh?
irrespective of the gestational age, we are giving 300 micrograms
Yeah,
only,
yeah,
no?
we are giving 300 microgram. So before they used to tell 50 microgram, 300 microgram, but presently we need not, because we are not calculating the requirement, we are giving 300 microgram for all cases. And next, cervical preparation. Yes, cervical preparation can be given. Oxytocin only after evacuation it is recommended. But if there is acute bleeding or if the mother's hemodynamic status is not maintaining, you can start oxytocin even during the time of evacuation with the risk of embolization. But still, if there is acute hemorrhage or if there is hemodynamic compromise, start oxytocin. But if there is no bleeding, if the mother's vitals are stable, only after post evacuation you have to start Synto drip. What is the role of repeat curettage? Only if there is any evidence of repeated vaginal or persistent vaginal bleeding, or if there is any retained products on ultrasound, you have to do a repeat curettage. Otherwise, there is no role of repeat curettage. Now, this is very important. What is the HPE? So, HPE in abortions and role of UPT. So, what will happen? So, once you have done a molar evacuation, if sorry, not in molar evacuation. Now we are thinking it's an abortion. So you don't know whether it's a partial mole or if it's a missed abortion or it's an incomplete abortion. You don't know anything. It was just an abortion. You have done surgical evacuation and you have got the products of conception. If possible, send the products of conception for histopathological examination to be on a safer side. Okay. So if histopathological examination is going in favor of either complete mole or partial mole, do a routine beta HCG follow. Okay. If histopathological examination is not done. So for example, in our institute, they don't send the products of conception for HP. So we discard the products. So what you have to do to rule out GTN or persistent GTD, you have to do a UPT after 3 weeks of evacuation. So if the urine pregnancy test is positive after 3 weeks of evacuation, then you have to do a serum beta HCG and monitor her to rule out the possibility of persistent trophoblastic disease. Understood? So, if possible, send it for histopathological examination and you know whether it is a abortion or incomplete abortion or a or a complete mole or a partial mole and you're safe. If it is a partial mole or a complete mole, start beta HCG, follow up. If it is an abortion, leave it. But if you have not sent for histopathological examination, do a urine pregnancy test after 3 weeks. If it is positive, then you have to rule out the consequence of persistent trophoblastic disease. So that is why you have to do a serum beta HCG and the follow-up post that. Because 50% of moles, 25% of normal pregnancy, 25% of abortions and or ectopic can progress to GTN. So it is not only the molar pregnancy which can progress to GTN or persistent trophoblastic disease. Even in a normal pregnancy there is risk. Even in abortion or ectopic there is risk. So if you are not sure whether it is an abortion or a molar pregnancy, please do an UPT after 3 weeks. And even if it is a medical management, so for example, you give mifepristone, misoprostol, then you do a check scan, everything is clear, abortion is over. So how to know whether was a molar or it was an abortion? Even for such cases, after 3 weeks, do a beta HCG. So if you do a beta HCG after 3 weeks and if it is negative, it was just an abortion. But if it is positive, you have to rule out the possibility of persistent trophoblastic disease. So then you have to do a serial beta HCG monitoring by doing a serum beta HCG. Am I clear?
Yes, sir.
Okay. So GTN after a non-molar pregnancy. So usually after a non-molar pregnancy, that is after a normal pregnancy or after an abortion, is always choriocarcinoma. So this is a golden rule. So in GTN, there is invasive mole, choriocarcinoma, persistent placental site trophoblastic tumor, and epithelial trophoblastic tumor. So after a non-molar pregnancy, if there is GTN, it is definitely choriocarcinoma. Other three will be only the sequelae of molar pregnancy. Understood? What about co-twin? So there are two sacs. One sac as a normal fetus and one more sac as the molar pregnancy. So what will you do? How will you diagnose? So this is around, the incidence is very rare, 1 in 20,000 to 1 in 1 lakh. So that is the very rare possibility where one twin has the normal fetus and one twin has the molar pregnancy. So how will you diagnose? The main thing is karyotyping. So you will do an amniocentesis from the twin sac and you will do a karyotyping. If it is diploidy and if it is not anything like triploidy, then it is a co-twin. And if it is karyotype is normal, it is a co-twin. But if it is triploidy, it is a partial mole. It's a partial mole along with trophoblastic disease. So by doing a amniocentesis and prenatal diagnosis, you will know whether it is a co-twin or if it is a partial mole. So once you know whether it is a co-twin, you have to counsel the woman because the chances of development of GTN is very high. So there is 20% chances of development of GTN in the presence of co-twin, and also the high chances of development of preeclampsia and preterm labor. So all these complications you have to explain to the mother, and serial ultrasound follow-up for any fetal growth restriction or maternal follow-up for preeclampsia has to be done. Once if she tells everything is okay, I want to continue the pregnancy, there is 51% of chances of live birth. But usually sometimes it might result in intrauterine fetal demise also. So the prognosis is slightly bad. So you have to explain to the mother whether she wants to go for termination or she wants to continue the pregnancy with all these additional risks. If she wants to continue, you have to monitor her for preterm birth, preeclampsia, FGR, and also you have to tell the chances of live birth is around 50%. So that is the management of co-twin and trophoblastic disease. And as I already mentioned, the placental site trophoblastic tumor and epithelioid trophoblastic tumor, they both are chemo resistant. So you cannot use chemotherapy in them. You have to do a hysterectomy, that is surgical management. And optimal treatment of GTN is always based on the WHO criteria that I will be discussing in the GTN class, and long-term outcome. So either it is a molar pregnancy, the chances of recurrence, if there is one molar pregnancy, it is around 1 to 5%. But if there is two molar pregnancy, it is around 2 to 10%. The chance of recurrence is slightly high. And even the GTG tells the contraception until beta HCG is normalized, give barrier method. After beta HCG is normalized, give oral contraceptive pills. But don't use intrauterine contraceptive device post evacuation because there is high chances of uterine rupture. So this is the summary of the guidelines according to GTG number 38, that is RCOG guidelines, which was amended in September 2020. Okay. So my last slide, what is the take home message? What all things you have to know about molar pregnancy? So GTD, it's a abnormal trophoblastic proliferation which occurs, and it has two types of disorders. One is benign disorders and one is malignant disorders. In benign, there is molar pregnancy. It could either be complete molar or partial molar pregnancy. In malignant, there is invasive mole, placental site trophoblastic tumor, epithelioid trophoblastic tumor, and choriocarcinoma. So once you have got to know either it is benign causes, that is our topic of discussion today, you have to differentiate between complete hydatidiform mole and partial hydatidiform mole. So you have to know the pathogenesis, the risk factors, and the incidence. So incidence in India is 1 in 400, but it is more common in high ethnicity or races like African and Oriental countries like Philippines, China, Japan, where the incidence is as high as 1 in 80. And risk factors, maternal age and other previous history of moles, all these risk factors are really important. And pathophysiology behind a complete hydatidiform mole, where there is an empty ovum with fertilization of a single sperm and endoduplication, or two sperms, that is dispermy, can occur. But in a complete mole, there is triploidy, where there is a ovum with either two sperms which are going and fertilizing a single ovum, that is triploidy, that is 69XXX or 69XYY or 69XXY. So these are the three things in partial mole. And we have to know the differences between a complete mole and a partial mole. In complete mole, there is only abnormal proliferation of the trophoblast, where there is diffuse trophoblastic proliferation and there is no fetal parts. Whereas in a partial mole, there is presence of fetal parts, and this is the basis of P57 KIP immunostaining. And we have to also know the hypothesis behind development of molar disease, that is both Park's hypothesis and Hurtig's hypothesis. Hurtig's is more proven, which results from the death of the embryo to the development of inclusion cysts. So after these, the common clinical features of complete and partial should be known. Complete has more pathognomonic features, but partial mole just presents to you with like a missed abortion or a incomplete abortion. And we have to do the relevant investigations, blood investigations, ultrasound with Doppler, chest x-ray to rule out pulmonary embolism. And if she has any features of metastasis, you have to do a CT or MRI. And the gold standard management for a complete hydatidiform mole should be suction and evacuation followed by a sharp curettage. If the fetal size is more in partial hydatidiform mole, do a medical abortion followed by a sharp curettage. And we have also understood the role of cervical preparation and oxytocin. And the most important thing in molar pregnancy is the beta HCG follow-up. In complete mole, weekly till 56 days. If it comes back to normal within 56 days, monthly from the date of evacuation. If it does not come back to normal within 56 days, monthly from the date of normalization. In partial, weekly we have to do till the normalcy. Once normal, you have to repeat after 4 weeks, that is 1 month. 2 consecutive values are normal, no need of further follow-up. But if there is raise of beta HCG in first 2 weeks, or if there is plateau of beta HCG, that is less than 10% decrease in the first 3 weeks, or if the beta HCG has not come back to normal within 6 months, or if there is any histological features of choriocarcinoma, definitely these are all risk factors for persistent trophoblastic disease or gestational trophoblastic neoplasm, where prophylactic chemotherapy or staging of the disease is required. And we have to know what is the role of hysterectomy and what is the role of chemotherapy in post-molar cases. And importance of beta HCG. How does it cause hyperemesis, thyrotoxicosis, preeclampsia in molar pregnancy is important. What is hook effect and what is phantom beta HCG is equally important. Understood? I think I have covered most of it. And we will deal about GTN when we come about when we cover malignancies in gynecology. That time I will brief about molar pregnancy in 10-15 minutes, and only the sequelae of molar pregnancy, that is gestational trophoblastic neoplasia. What are the types? What is FIGO classification, staging of the disease, and the algorithm to manage GTN we will discuss in that class. Am I clear with molar pregnancy? Any
Yes, ma'am.
doubts?
Ma'am, role of medical management in ectopic molar pregnancy.
Ah, Role of medical management in ectopic molar pregnancy. Usually, if ectopic and it is a histological diagnosis. So, if you have given 2 doses of methotrexate and still the beta HCG is persistently rising, then we have to go for surgical management. So, if you have planned for you have an ectopic pregnancy, you don't know whether it is mole or a normal ectopic. So, that time the beta HCG values say about is around 1200. So that time you will tell, okay, we need not go for surgical management. You will just give medical management, methotrexate. So 2 doses of methotrexate you will give 24 hours apart. So first dose you will give, one day you will give a gap, next day you will give 2 doses of methotrexate. And still if the beta HCG is not falling and if it is raising, then you have to do a surgical management. Then obviously you will do a salpingectomy and you will send for histopathology. And on histopathology, if it is proven to be molar ectopic pregnancy, the follow-up will be as same as an intrauterine pregnancy. So post follow-up, you will follow up with beta HCG in the same way. That is ectopic molar pregnancy.
Ma'am, if per se, if HCG is more than 20,000 international units after 4 weeks of evacuation also, ma'am, we are going to start methotrexate. Still, we are going to do weekly beta HCG only, ma'am.
We have to do that is prophylactic chemotherapy. Even if we are giving prophylactic chemotherapy also, post that we have to do weekly and monthly till it comes back to normal. So if it is not coming back to normal, then you have to think of GTN. And that time you have to give full course chemotherapy. In prophylactic, you will give only a single course. But in if you have already suspected GTN, that time you have to give multiple cycles. That I will discuss whether you have to give a single agent or a multiple agent like immunotherapy or there is something called as EMA, EP therapy. All that I will discuss in GTN class. Any other doubts?
No.
Okay. Do you have any other doubts in any other classes? Yashaswini, did you go through antepartum fetal surveillance class?
Ah, yes, ma'am. I went through.
Okay. Do
I
you
have to
have any
finish it
doubts?
off. No, I should finish the Doppler video, ma'am, the separate video which you have done.
Yeah,
That
yeah.
I
So I have not covered Doppler and CTG again in the class because
Mhm.
there were separate detailed videos on that.
Mhm.
So go through that, and if you have any doubts, you can ask me anytime.
Yes, ma'am.
Okay, you have any feedback to tell, or am I fast, slow, or should I stress, repeat anything? Any
So,
feedback is always welcome because negative criticism is even more important for betterment. So everyone will be like, everything is nice. So I'll be thinking some feedback is important in each class so that even I improve. This is the first time I'm starting the course, right? So if I get a genuine feedback from students, it will be like even in upcoming classes, I can give you my best.
no, ma'am, it's actually well explained. Like, there are so many things which we do, which we didn't know, like, which are clearly explained, and especially the guidelines are not like no one covers guidelines properly. It's
Yeah.
very difficult to follow up with the guidelines. Even in textbooks, also, if we follow old edition, the things which are new are not given, and there's always fear of missing out on something. So this is well covered lectures actually.
Well, for example, see now, if I have to take a class, I go back and study my PG notes. So in my
Mm.
PG notes, still beta HCG follow-up is weekly beta HCG and then monthly. So it has this 56 days concept is not there in even Novax. It was not there in Novax that time. So my notes doesn't have that. But once I did MRCOG and I read the GTG guideline, it is clearly told that it is 8 weeks and like this you have to do for a complete mole, partial mole. So yeah, the evidence is like that because so many books don't cover guidelines. We will not know what is the present consensus of management in any case, not only molar. In any case, what we have to do is what is important. Irrespective of exam point of view, further after PG, you have to know how to manage a molar pregnancy because if they ask beta HCG follow-up, you can't be confused that time. So I feel guidelines is, see, some old school people tell it's guidelines are not everything. You have to do an experience based management. Yeah, that is equally important. I agree to it. But guidelines save you from many things. You will not have a confusion. So theory is important, practical knowledge is important, experience is important, but evidence-based medicine is equally important. So if you know the algorithm for each case, your job is very easy. You need not think. So if she comes any case, for example, GDM, this is the guideline. You follow that. It will save you and the patient. So the main purpose of my course and classes was to inculcate the guidelines in theory part also. So that is the because in other platforms, no, they don't cover as much as guidelines.
Yes.
So they cover mainly textbooks. So
Mm.
so I thought I will include both textbooks and for each class, my last slide should be guidelines and what does the evidence say and what to practice. So that time you will get a final picture. Okay. So yeah, I will be sharing that GTG guideline on the group also, as usual.
Yes.
So once you go back and you can watch this video again for better understanding, and you can go through that GTG. If you are not able to go through the entire GTG, it is okay. There will be something called as an executive summary in the starting of the GTG. And in ACOG, there will be uh, current recommendations or summary of recommendations at the end. So if it's an GTG article or an RCOG article, in the starting only there will be something called as executive summary. In an ACOG article, there in the end there will be summary and recommendations. So if you go through that much, it is more than enough at the level of post graduation. You need not read the entire guideline. The summary is enough. So if I share, at least take some 10-15 minutes to read that so that you will understand better. Okay. Okay.
Yes.
Thank you. Keep
Thank you, ma'am.
studying. We'll meet you tomorrow. Bye.
Thank you, ma'am.